So the first presentation tonight is on approach to urethral obstruction in cats and dogs. Then we've got another on head trauma of septic patients, pleural effusions, and also acute abdomen. So on our social media and also on our website you should see the additional CPD days and registration details. My name's Becky Sedman, I'm the lead night vet here, and I'm currently studying for my BSAVA ECC certificate. So, this evening we're going to cover stabilising the blocked patient, managing electrolyte disturbances, safe sedation protocols, extra techniques for unblocking, what we do when unblocking doesn't work, and the initial aftercare in the hospital. So we're going to go through everything in a chronological order, from when the patient comes in to then when it's discharged, and then we can have plenty of time for questions at the end as well. So, it's, well, obviously home field's an IVC practice, isn't it? So you might be aware that IVC actually have some really good care frameworks on the website. So it's aimed at first opinion practitioners, and you can see they've basically got lovely flow charts for a lot of common emergencies. And I've just blown up one of the treatment sections here, but a really good CPD opportunity and just extra resources if you're in practice and you just want, you know, something to have a quick read through before you unblock a patient. But I just thought I would signpost that if people weren't already aware. So we all know how a blocked patient presents. Very painful, unproductive urination, sometimes hematuria, looking at their back end, sometimes very lethargic, sometimes vomiting, and often when we see a lot of blocked patients out of hours, as you can imagine. I'd say the majority of them are usually quite well. However, you do get the odd patient who is really, really poorly. You know, they've become blocked, they've hidden away, someone found them under a hedge in a few days later, and they are really poorly patients. So when a patient comes into us, if a vet can't see them within kind of half an hour or so, we ask one of the nurses to triage them and take them down the bottom, get permission from the owners to pop an IV in and give them pain relief, and obviously get a weight. And then when we do initially do our clinical examination, the main things we want to look at is heart rate. They might be tachycardic because they're painful, because they're stressed, because they're hypovolemic, sorry. Or they might be bradycardic, which would be more of a concern because, I mean, to be honest, if cats are a bit shocky, they can sometimes be bradycardic, or if they're hyperkalemic, and then they are bradycardic, and sometimes have dysrhythmias as well. Respiratory rate, again, might be tachypnic because they're stressed, because they're painful, potentially if they're acidotic and then they're trying to compromise, or if they're very, if they're not breathing very fast at all and they're very kind of comatose, again, maybe a bit of concern that they're extremely acidotic, and we need to keep a really close eye on them. And again, also, not just blinkering ourselves to think it's a blocked patient, they could have other comorbidities that we need to be aware of. So ECC, most of it's all about identifying signs of shock and then stabilising our patients. So we want to look at our 6 main perfusion parameters. So heart rate we've already discussed, capillary refill time, whether it's really brisk, whether the mucous membranes look, well, whether they're very injected and you've got a very brisk refill time, whether it's a very slow refill time because they're extremely hypovolemic, the mucous membrane colour, whether it's pale, whether it's brick red, whether it's some other funky colour we definitely need to be worried about. The pulse quality, we always want to check their femoral pulses and also the metatarsal pulses, which gives us a good idea as to, again, how shocky they are, and whether we need to also then follow that up with a blood pressure measurement when the patient is a little bit more stable, or at least less stressed, let's say. Mentation, if they're again obtunded, bit of a concern, and also extremity temperature, because that's kind of a good representation of what the capillary beds are doing. So next thing, bladder palpation, really important. Have they got a really firm, turgid, enlarged bladder? In which case they probably are blocked. You can give it a gentle squeeze and see if you can express any urine manually. Often this is very painful as well. And if you can't, then again, let's treat them as a blocked patient. Looking at their hydration status, now that's different to being hypovolemic. So your hydration status is kind of your extravascular fluid compartments, whereas hypovolemia is a loss of intravascular circulating volume. So 2 different fluid therapy plans based on hypovolemia versus dehydration. And also temperature, do we need to warm these patients up? So first things first, give the patient some pain relief. It's really painful. I would go straight for methadone, 0.2 mg per kg, IV or IM. We want to avoid NSAIDs because our patients are already prone to having they might already have an AKI, and in which case we don't want to cause vasoconstriction of the kidneys and worsen that AKI. To be honest, any patient that you're concerned about shock, I'd just hold back from the NSAIDs. Gabapentin in cats, pain relief, also anxiolytic, especially if they're presenting because it's spasm and they've got FIC or fluted. Paracetamol in dogs is good, and we're also going to mention epidurals later as well, because that's obviously another very good form of pain relief. So then we want to get some bloods from them, and I'd say as a minimum we want to do some blood gases. So you may have an EPOC or an ISTAT machine in practice, but what we want to mainly focus on is the pH or the acid-base status. Often these patients they do have metabolic acidosis, and that's because the body just can't eliminate hydrogen ions. So it builds up, they develop acidosis, and they often haven't got time to, develop kind of respiratory alkalosis to compromise that. Potassium as well, unfortunately, because they're not excreting potassium, they can become hyperkalemic, and I say that is one of the most critical things that we need to treat straight away. Looking for azotemia. Checking glucose, they probably are going to be stressed, they might be a bit hyperglycemic. If they're hypoglycemic, could they have a septic uroabdomen? Could they just be really, really poorly and they haven't eaten, they've been vomiting for a few days? Ionized calcium, again, they can sometimes be hypocalcemic, which needs treating. PCB and total solids, which is a marker of dehydration. And lactate, which is our main marker of perfusion. So we say if the lactate is above 2.5 in dogs or 3.3 in cats, they are likely hypoperfused, and then we need to fluid resuscitate them. So, in terms of fluid therapy plan, the first step is to correct hypovolemia. So that's by giving them fluid boluses. So typically 10 ml per kilo over 10 minutes in dogs, and then 5 ml per kilo over 10 minutes in cats. Just because cats are smaller creatures, so they're more prone to overload, and you want to give it basically one at a time, check the perfusion parameters, see if you need to give a couple more. Fluid of choice for blocked patients is always a buffered isotonic crystalloid like Hartmann's, and that's because they could well have acidosis, and in which case the bicarb in the Hartmann's is going to counteract that. And then once we have unblocked our patients, we need to then match the fluids ins and outs, because obviously all these solutes have been building up in the bladder and in the kidneys, and when it's finally excreted, all of the water will follow behind them. So they get a condition known as post-obstructive diuresis, which is where their urine output is very high for a period of time. And we need to then match the fluid rate, the intravenous fluid rate, to make sure these patients don't become increasingly hypovolemic and dehydrated. So we tend to typically measure the urine output, because we've got a closed urine collection system, every 2 to 4 hours, and then match the fluid rate accordingly. We do say though, however, up to a maximum of about 8 ml per kilo per hour, because after that you don't want to almost make the problem a bit worse. But again, fluid ins and outs is really important the first kind of 24 hours after you've unblocked a patient, and also then we'd account for rehydrating them as well. So obviously, if you're going to give a patient fluids, you're a little bit concerned that the bladder's already really full, where's it going to go? Cystoing is controversial. Some people aren't fans because there is the risk that the bladder could rupture, particularly if the patient's wriggling, or if the bladder's already going semi-necrotic and is very delicate. So rupture is a true risk. However, I personally would always cysto these patients, but I just make sure that I use a really small gauge needle and a butterfly needle, so it's only one needle stick. Drain the bladder entirely so that you again minimise the number of times you have to do this, and also if the bladder's smaller, you're less likely to get urine leakage afterwards. So yeah, I personally like cystoing, but you've just got to be aware that the patient has to be sufficiently restrained and try and minimise as many needle sticks as you can. The other thing as well to mention is if your patients are unstable, we're going to talk about correcting electrolyte disturbances now, but you might need to have your patients on fluids for a few hours before they're stable enough to then actually sedate and unblock, in which case you're going to probably want that bladder empty to allow for that to happen. Okay, so electrolyte disturbances. So hyperkalemia is defined as a potassium of over 5.5 millimoles per litre. Over 7.5 is life-threatening, and we're looking for signs of muscle weakness, but primarily ECG changes. So you could have atrial standstill, you could have spiky T waves, we could have bradycardias, we could have dysrhythmias. And if you notice any dysrhythmias, / if you have got a high potassium level, I'd be giving calcium gluconate IV. So you do that, I've given a dose here, 1 ml per kilo, diluted with saline, not Hartmann's. And you want to do that slowly IV over about 10 minutes, and you could hook them, well, I think it's sensible to hook them up to the ECG anyway, and just check their trace as you're doing that. Now, important to mention that the calcium gluconate doesn't actually treat the hyperkalemia, it just helps to protect the heart from the effects of hyperkalemia. So as well as protecting the heart, and also you can, really good idea to do this when we're sedating them, but also in the kind of period up to the point where we sedate them, you can repeat that as well a couple of times, because it only actually lasts for kind of 20 to 30 minutes. So, to correct hyperkalemia, hopefully with a few hours of fluids and relieving the obstruction, which you're initially going to do by cysto, you want to just have them on crystalloid fluid therapy and obviously your fluid resuscitation plan, and hopefully that should drop the potassium level. If that doesn't work, then you could add in glucose 2.5% CRI, because then when the cells take up the glucose, they also carry the potassium with them, therefore dropping the potassium levels in the bloodstream. Or to speed that along, you also give them some neutral insulin. So you can give that IV or IM, and just make sure you're simultaneously giving the glucose so the patient doesn't become hypoglycemic. Failing that, terbutaline, bricanyl is another option. And then the last option would be sodium bicarbonate IV, which is also what we'd use to correct an acidosis. However, I wouldn't rush into that because there can be additional complications with giving that, so you'd only use it as a last resort really. But primarily I think actually they tend to improve sufficiently to then unblock them with, once you've given them fluid therapy and boluses to correct the hypovolemia. So if you've noticed hypocalcemia, that can be because obviously the kidneys and the bladder is not excreting the phosphate, so it's binding to calcium and dropping your systemic calcium levels, which not only does that then exacerbate the sensitivity of the heart to any simultaneous hyperkalemia, but you could see muscle twitching, weakness, seizures, or facial pruritus. So again, we can treat that actually in a very similar way to how we protect the heart with hypokalemia. So it's a similar dose, 0.5 to 1.5 ml per kilo, slowly IV, and again ECG monitoring, and you can see the result that lasts for kind of 20 to 30 minutes, and give a little bit more if you're not seeing resolution of the clinical signs, if the patient is clinically affected. And last but not least, acidosis. So again, with the Hartmann's, you're hopefully going to be correcting this, and actually once the patient is then unblocked, it should resolve with its own accord. But when patients are severely acidotic, they can be really poorly, they can be very comatose, and it does mean you're at an increasingly high anaesthetic risk, so we just need to be aware of this. And sodium bicarb, if despite your best efforts with fluid therapy the patient remains acidotic, you can give them sodium bicarb IV. It's quite an awkward calculation to work out, but yeah, it should be available and you can do it, and it does have a good impact if and when you need it, but only in the right circumstances. So why are our patients azotemic? So they're going to have a degree of post-renal azotemia, so just because they can't excrete the metabolites and the electrolytes, and all the toxins then build up in the bloodstream. So actually once you've relieved that obstruction, post-renal azotemia should resolve. You're going to have a degree of pre-renal azotemia because your patients are going to be inappetent, vomiting, and very dehydrated. So again, you can correct that with your fluid therapy plan. And then most concerningly, they can have renal azotemia or an AKI because of kind of prolonged damage to the kidneys. Now, you'd know that because actually we typically tend to kind of recheck the patient's bloods if they were azotemic kind of 12 to 24 hours afterwards, and if they are still azotemic and it doesn't seem to improve, you are then dealing with an AKI, and you manage that patient as an AKI. So monitoring the urine output to make sure it's not dropping, make sure they're not producing any urine at all, which would be a concern. And then also you've got to be conscious that if their urine output is dropping, you're not going to fluid overload them with your intravenous fluids. Managing blood pressure, making sure they're not hypertensive, and managing electrolyte disturbances. So imaging. So again, ECC, we love focusing everything. So I typically focus the chest and the abdomen. Things to look out for is free fluid in the abdomen. Now, a little bit near the bladder is normal because there's a lot of inflammation, but if there's a lot of fluid there, obviously the worry is that the urinary bladder probably has ruptured, in which case you can sample that and just make sure it's not urine. Check the thickness of the bladder wall. If it's very thickened, it's probably a chronic cystitis, definitely, potentially a chronic UTI. Evaluate the prostate in entire dogs. We've had a few blocked dogs just because their prostate is so enlarged because of BPH or prostatitis, and that can actually cause urethral obstruction in itself. Checking for evidence of stones or sediment, most importantly, because you're going to do an x-ray as well, or I'd encourage you to do an x-ray as well, but if they're radiolucent stones, you're not necessarily going to see them. So actually, then if you've scanned as well, you've hopefully picked them up on one or the other. And then x-rays. So one lateral abdominal radiograph is usually sufficient, and that will pick up radiopaque stones. Obviously evaluate the whole of the urinary tract, and you may need to position the dog or the cat with their hind limbs in different positions just to make sure you've visualised the whole of the urethra. And if you are concerned about any urethral strictures or tears, and therefore looking for urine leakage or radiolucent stones in the urethra, we can also do a contrast study, which again we're going to discuss. So a couple of examples. You've obviously got this is a dog here, so there's a huge cystolith there, and also it had stones in its urethra, the distal os penis, which you could just about pick up on the left x-ray, but actually when we move the legs forward, they're a lot more visible. So yeah, a couple of positions is usually beneficial. And then just for interest's sake, I put that ultrasound picture there because it's actually a bladder mass, and the reason we know it's a bladder mass rather than a stone is because you can tell the texture of it is very similar to the soft tissue structures around it, but there's actually no acoustic shadowing. Whereas if it's a stone, therefore a really dense material, you're going to see the picture drop out and it should be just a black shadow underneath, whereas we're not seeing that with the mass. So how do you diagnose a uroabdomen? Hopefully they don't have a uroabdomen, but it's useful to just briefly discuss it because it's fairly concerning if they do. But again, blood work's going to show azotemia and hyperkalemia, and then you have identified free fluid in the peritoneal space, which you can then sample. Run a renal profile, so put the actual peritoneal fluid through the biochem machine and get a renal profile on it, and then if you compare the creatinine value of the blood versus the peritoneal fluid, if the peritoneal fluid is double that, then it's fairly diagnostic of a uroabdomen. And then we need to stabilise the patient and then figure out obviously where the leakage is coming from. So stabilise, as we've discussed, fluids, correcting any electrolyte disturbances. You do contrast radiography to locate the cause of the leak. So you can do retrograde to diagnose things like urethral tears or bladder tears, but if it's actually something higher up, like a urethral tear, you're probably going to want to do intravenous contrast studies, which is a topic for another day. And we pass those on to the medics. But yeah, if you can then put a catheter into the patient and make sure the bladder is kept small while you're stabilising them, and also drain the peritoneal fluid and possibly put even a Jackson Pratt drain in, so you're constantly draining the urine off to avoid it being in. Well, it's really irritant having urine in the abdomen and very painful. And obviously, if they've already got a UTI, there's a risk of them becoming septic as well, and then probably going to need surgical correction. So positive contrast retrograde urethrogram, which is a bit of a mouthful, but we talked earlier about it's being very beneficial to identify urethral strictures or tears, or radiolucent stones, which we can see actually on this picture. There's some radiolucent stones in the urethra there, which has been identified by that positive contrast. So how do you do that? You need to use an iodine contrast agent such as Omnipaque, which is the same stuff we'd use for CT scans. That needs to be diluted to a specific concentration, and then depending on the size of your patient, you need to pre-fill a syringe with that contrast agent. Pop your urinary catheter into the penis just at the tip and secure it in place so it can't leak out. And then once you inject your agent, you want to really quickly take a radiograph. So that often means having someone actually in the x-ray room with the patient and just wearing all the correct PPE. Another option will be to have them outside of the x-ray room and then have a long line on them, but a little bit more faffy. So yeah, and it's a little bit harder to know how much fluid you need to actually flush it into the patient, but can be really beneficial. So sedation protocols. So once we stabilise our patients, we feel they're well enough to undergo sedation / general anaesthetic. What we want to avoid is alpha-2 agonists, because they already potentially have an AKI, and an alpha-2 agonist is going to cause vasoconstriction, including in the kidneys, to reduce renal blood flow further. So avoid alpha-2s. Your other options then are ACP and benzos, which are also muscle relaxants and may well relax the urethra to some extent, and avoiding cardiorespiratory depression if possible. So you could use ketamine, and I've put that as one of the options. I suppose the downside to ketamine is it can cause respiratory depression, and also if the patient is then really dysphoric on recovery and they've got an IV line in, they've then got a urinary line in, and they're going a little bit crazy in their kennel and they're twisting round, then it is a bit of a nightmare. So it is an option, and ketamine mixed with a benzo would certainly produce suitable anaesthesia. The other option is then, opioid and benzo. I like methadone and midazolam personally, and if it was a cat I would then use Alfax, and if it was a dog I would use propofol. But so as long as we're avoiding alpha-2s and cardiorespiratory depression as much as possible, that will benefit your patient massively. So if we want to do an epidural, now the patient does need to be sedated in order to place it. However, I suppose if you've got a patient with concurrent comorbidities and you want to kind of minimise the amount of sedation required or avoid a GA, then doing an epidural would be an option, and it would obviously produce dilation of the urethra as well, which can be beneficial, and obviously very good pain relief for about an hour. So you need to clip and aseptically prepare the patient, and then pump the tail up and down to find the most movable space. Now that will either be the sacrococcygeal space or the coccygeal space. And then use lidocaine, making sure it's preservative free, a small gauge needle, and just pop the needle gently at a 45-degree angle into the space, and you should feel a little pop. And then if you apply negative pressure, you shouldn't be able to draw anything out, so certainly no blood, and there should be minimal CSF at that site as well. And then when you put your lidocaine in, it should go in really easily. If there's resistance, then you're probably in the wrong spot and you need to try again. And then within a few minutes that should work, and you should notice that there's reduction in anal tone, just a flaccid tail, no motor function of the limbs, and obviously absence of any sensation. So tips for unblocking. I'm sure you've all unblocked plenty of animals before, but I think it really helps when you know where the issue is and you've chosen the correct urinary catheter, which we're going to talk about on the next slide, making sure it's a suitable catheter for unblocking, and then again putting a suitable catheter in for long-term use. Clipping the area and aseptically preparing. I like lateral recumbency, some people go for dorsal recumbency, so whichever you find easier. If we're concerned that maybe it's like a gritty cat penis, then you can gently massage that to try and remove as much grit as possible. Retropulsion with saline, and to be honest, I put lube in it as well because I think it just helps shift everything along. You could also try lidocaine gel. We tend to have kind of packets of sterile lidocaine gel for putting urinary catheters in our dogs typically, but actually it can work quite well when you're unblocking a patient as well for some additional pain relief. And the other thing you can do is do a rectal exam and just pop a finger in the rectum to feel for the urethra, and then you might even find a stone. Sometimes if it's located in the pelvic urethra, you could potentially know where it is, which will help to shift it along. or you can pop your finger with a lot of pressure on the urethra, and then you're still doing your retropulsion, but it means that the pressure is going to build up and dilate the urethra to such an extent that when you take your finger off, it should all whoosh through, and then hopefully give you a little bit of an extra push to get that stone or the grit back into the bladder. So it tends to work better on dogs than cats, understandably, but yeah, it's also a good trick to try. You can use an IV catheter or a lacrimal cannula in cats. And obviously with all these things, just avoid being too forceful, because we don't want to cause any damage or tear to the urethra, which is going to result in urine leakage or stricture formation. And then once you pass your catheter, flush it thoroughly. So make sure that the urine's then coming out clear. Then you're going to remove any crystals, blood, inflammatory mediators, and to prevent if there's an infection, try and flush out any bacteria as much as possible. So which urinary catheter do you want to use to unblock? Now with dogs, we typically just use a rigid urinary catheter. It doesn't have a stylet in it, but it's really rigid and does the trick. With cats, you want to use either a Jackson or a slippery Sam. And we've also got these special Miele urinary catheters, which I'm going to actually pass around in a second or two. But the unblocking catheters, they want to be stiff and with an end hole, and also with a stylet in. So they need to be kind of rigid enough basically to actually sufficiently unblock. And then to stay in longer term, you want a softer catheter that's not going to cause much irritation, and has side holes in it, which means it's less likely to block from any kind of debris or sediment that's in the bladder. So typically we would, and with the dogs also, we just put a Foley balloon in because they stay in really nicely. But typically with cats, say, we would unblock with one catheter, take it out, and then pop another one in for longer term use. However, there is a product called a Miele cat catheter, which is a really fantastic product. It's new to us, so I can't say I've got first-hand experience in it, but Andrea has, and it was his suggestion, and they do look brilliant because they do two jobs in one basically. So they're rigid enough with a stylet to unblock, but then you can remove the stylet, and the plastic actually, with warmth from the body, it kind of goes flexible and is really comfortable to stay in. And then you can move it, so you can adjust this yellow bit to the correct size of the patient, because half the time as well, if the catheter's not the right length, then they just don't work and we have to replace them, and it's can be a bit of a faff really keeping them in. So with this, you can make sure that they're sufficiently into the bladder based on the size of the patient, and you can confirm that with a scan, and then just adjust your little yellow whatever this bit's called, it's probably got a fancy name, and you can just suture that onto the patient as normal. And then we always have a closed urinary collection bag on our patients. If they are tangling themselves and we can't keep the bag on them, then we would take it off and just manually drain, but we would never leave a catheter in just open to drain to the environment, because there's just too high a risk of infection. So always have it closed off, ideally with a bag on, because then you can constantly be measuring urine output and also seeing what the urine looks like, but manual drainage every kind of 4 hours if not. So pass it round to you all if you want to have a little look at that. So if you can't then unblock, which is always a pain because you've probably been trying for ages and it just doesn't seem to be shifting, there are various surgical options. So with cats, we tend to go for a perineal urethrostomy, which will also be the treatment of choice if they've had over 3 episodes of spasm. You of course always need to treat the underlying FIC, otherwise they're still going to have ongoing cystitis and bladder issues. For dogs, we tend to do a scrotal urethrostomy, plus or minus castration. So I say plus or minus castration because dogs can also get cystine stones, which are, if they're male entire, they are predisposed to, so probably will benefit from castration from that perspective. Plus also where the urethrostomy site is where the testicles were, so we have to do 2 in 1. You can do a cystotomy and antegrade flushing, but then I suppose you could end up doing that, and actually if you can't shift it, you're still going to have to do a urethrostomy anyway. So it's just, I suppose, go into that being prepared to do both procedures at once if it doesn't seem to work. And as a temporary measure, you can either keep cystoing until the surgeon's in the next day to do the procedure, or you could pop in a pigtail catheter or cystotomy tube, which would enable you to keep draining the bladder and buy you a little bit of time. But again, sometimes there is the risk of urine leakage, and sometimes they work fantastically well, sometimes they can be a little bit awkward, but it is an option. And then I would always, to be honest, said earlier, I tend to like cystoing my patients, and I would keep that initial cysto sample and then do my urinalysis on that. Equally, you could then take a sterile sample via your urinary catheter, but the downside to that is you've probably retropulsed some saline into the bladder and diluted whatever's in there, so it's probably better to get your very first urine sample in order to analyse initially in-house and then send away a culture and sensitivity. So you can do a USG, not that helpful if they've been on fluids, dipstick, look for protein and blood. Microscopy I think is the most important because we want to identify any crystals, bacteria, red blood cells or white blood cells. Send away urine for culture and sensitivity. Now, if the animal's going to have a cystotomy, then it's actually preferable just to take a slither of the bladder wall and send the bladder wall away, because then you're going to identify kind of deep embedded urinary tract infections. But if we are doing surgery, then yeah, send away a sample of the urine for culture. And if you do end up removing a stone, then you could send that for analysis at your normal lab. Or if you wanted a free service, you could go to Minnesota University, but there is quite a long lag time on getting the results back. Some people also say that it would be beneficial to check the urine microscopy once the catheter is removed, because obviously if you've got an indwelling catheter, there is an increased risk of a UTI, particularly if it wasn't entirely sterile when it was placed in the first place. So you've unblocked your patient, they're recovering from the sedation or anaesthetic. We're going to keep that urinary catheter in for 24 to 48 hours to make sure that the azotemia has resolved. So we would typically, as I say, do bloods kind of 12 to 24 hours afterwards, and then probably remove that catheter based on how the patient's doing. If the kidneys are fine, if the urine looks nice and clear, if they're doing well, and they potentially no longer have that post-obstructive diuresis, after 24 hours we might pull it out, or we might leave it in for a little bit longer, say if we still need to concentrate on the kidneys, or you know, sometimes the catheters come out and we've had to replace it. But always, yeah, with the closed urinary collection system, because we're measuring the urine output every 4 hours. Matching ins and outs with our fluids, as we mentioned earlier, maintaining them on analgesia. Question over NSAIDs, potentially if the patient is eating, obviously no GI signs, and their kidneys are okay and they're well hydrated. Some people opt for NSAIDs. I know a few medics who would avoid NSAIDs because, again, the kidneys have already been under quite a lot of stress, and for the potential anti-inflammatory benefits, they don't think it's worth risking the kidneys, but I guess it's a clinician preference. Anxiolytics in cats, we always have our cats on gabapentin. Historically, people used to use prazosin or phenoxybenzamine, but actually the evidence for this is really lacking, so we don't tend to use this unless there's a specific reason for that. Antibiotics, even if you've identified a UTI, I wouldn't be starting antibiotics until they've had the urinary catheter out, because you're just risking getting a resistant infection. And hopefully you've minimised the amount of bacteria that's in the urine by flushing the bladder thoroughly. You know, dilution is a solution to pollution, so hopefully we've at least reduced the infection load, and then once we pull the catheter out, we can then start the antibiotics, and also of course send the urine away for culture as well, and then follow up surgery if indicated. And then longer term, usually at this point we pass the animals back over to you guys and let them follow up with you about how you want to manage the cases, but essentially they need to be on long-term analgesia, probably non-steroidals, particularly with cats, if there's any FIC component, antibiotics. You might want to follow up with a urine culture and sensitivity after the course of antibiotics to check it has fully resolved. Diet change, if we're looking to dissolve any stones or try and minimise the risk of stones occurring in the future or crystals occurring in the future. Urinary supplements, wouldn't typically start this in the hospital if it was to stress the patient out, so it might be something we do as an outpatient, or sometimes if they're tolerant and it's easy enough to give, we might start in the hospital. Lifestyle or stress management for cats again,